So, so guys, we talked about the fact that ultimately, right, you guys are going to see a lot of UCL injuries at the thumb. Okay, so obviously, a UCL injury at the thumb is known as a gamekeeper's thumb or a skier's thumb. Okay? Generally speaking, this is what the mechanism generally looks like. So they called it a skier's thumb because ultimately people would essentially have their skin poles attached around their wrists. They might slip and fall, and they would essentially put like the thumb would get essentially kind of forcefully placed in valgus as they hit the ground, right? And so you can see that here where this is a classic mechanism for a skier's thumb. The same thing also happens though actually. Uh, in football or in a lot of contact sports, where the thumb is actually forced into valgus. Okay, and that causes tearing of the UCL of the thumb on the medial side, as you can see here. All right, now there are times, obviously, as like we talked about yesterday, it's extremely important to do a bilateral comparison. Okay, a bilateral comparison when doing your exam, so left versus right, to really be able to fully appreciate the laxity between sides. And obviously, if there is significant laxity on one side compared to the other, you need to get that patient in for an X-ray. Okay, so that we can assess right how much the joint itself actually opens up, right, and if it opens up significantly, then surgical repair may be needed. So we'll get them in for a stress X-ray. Now, there are obviously also um, there are also fractures that can occur, right? So with these injuries, so sometimes with a UCL injury of the thumb, you can actually have right what's called a Bennett's fracture. So a Bennett's fracture, you may want to write that down. So Bennett's fracture, and I'll put this all in a PowerPoint too for you guys as well. Um, but a Bennett's fracture is essentially an avulsion of the first metacarpal, right? Um, with that valgus stress. Okay. Um, so I'll show you another picture of it. So there's an avulsion fracture, but okay, if we had ultimately a Bennett's fracture with that avulsion, right? Here's what that might look like. So here's a you can see kind of a fracture at the thumb there. So this is actually a fracture at the base of the thumb. But okay, like we saw right back here. Okay, this was our Bennett's fracture and our UCL avulsion. Okay, so Bennett's fracture is when you avulse a piece of bone off of the metacarpal right at the time of injury. All right.
Is that just for the first metacarpal, or is that all five?
No, yeah, that's just for the first one. So we call it a Bennett's fracture only when we're focused on the thumb.
Okay.
Okay, only on the thumb. Yep. All right. So cool. Okay, so this guy's right here. This is a dislocation, obviously, of the carpal metacarpal joint. Uh, these are kind of crazy, right? So that's a bad picture. Okay, these are obviously thumb dislocations. Okay, so we have uh, here's the problem: if you have somebody that has a really high energy, like UCL injury or even lateral collateral ligament injury in the thumb, they can become unstable. I had a safety years and years ago that tore both the medial and lateral ligaments in his thumb during a game, and he just kept dislocating. His thumb would just constantly pop out. We had to pull him out of the game, and obviously he went straight into surgery and had his thumb essentially relocated, so and pinned. So here's another example, obviously, of a CMC dislocation. Right, you can see where the thumb has actually come away from the carpal there. So those need to be essentially, if you can reduce it, those are simply reduced via traction, but they need to be splinted immediately, right, and sent for reduction and possibly surgical repair. Okay. All right. I need to slow down. You guys let me know. Okay. Okay. So, all right. Let's talk really quickly. Okay, about uh, metacarpal fractures. Okay. Give me 1 second. We talked about yesterday um, that ultimately the tendency, right, of a long bone, okay, when it breaks, okay, is to essentially shorten. This is a bad one, obviously. Um, These are essentially displaced spiral fractures of each metacarpal, right? So you can see the tendency, though, right? When someone fractures a metacarpal, the tendency of the fingers distally is to rotate and or shorten because, right, the the proximal phalanx articulates right with the metacarpal. All right. So we talked about yesterday the importance of of observing for finger deformity and rotation in the presence of a metacarpal fracture. All right. So always, obviously be on the lookout for that, and just check for obviously rotation or evidence of shortening. Okay. So here again, right? You can see, right? This is actually a essentially a fracture at the most distal aspect of the metacarpal, right? Right. Obviously, at the physis, or where the growth plate was. Okay. All right. So sometimes these can be a little bit more subtle, so you have to actually look very closely. You'll see just a little bit of displacement of the distal aspect of the metacarpal on uh, the metaphysis of the metacarpal itself. All right. Obviously. Okay. Now the one thing that you'll notice, all right, um, if you notice with these fractures, guys, and you can see how this one is displaced. So the cortices themselves don't line up. Okay. So this one's going to have to be fixed operatively. Um, so what we notice here, guys, is that if you have somebody that's got a ton of angulation, or you have someone and you notice that the skin on the hand is puckering or almost kind of like tinting, you need to splint that right away and get them to a physician, or get them over to the hospital for reduction and surgery, because the bottom line, guys, is these can become open very quickly. So look for skin puckering, skin tinting, right? Look for changes in the kind of the tension of the skin, because that's going to guide you, right, as far as getting these people over um, for obviously for a reduction and fixation. Am I making sense? So let's stop for a second. Um, does this make sense, guys? Or am I just flying through this too fast?
Well, like you just treat the metacarpals as like they are a long bone, even though you may not think of it, but they're going to shorten and
Yep.
rotate.
Yep.
You're just going to have to like splint them and then send them.
Split and send them. You got it. Absolutely. Okay. Nice job. Okay. And you guys, literally, please stop me if there are questions. Okay. All right. So here we go. Um, obviously, guys. Okay. This is a big one. Um, crazy MCP dislocations. I actually had this happen to me my first couple of years as an AT. I was covering a football game in a really rural area, and this kid, you know, he came off the field and just had his hand in the air, and literally his finger was essentially taken, and it was like literally pointing the opposite direction at the MCP. So the good news is, guys, is that these types of dislocations are easy to reduce, and I think that you totally can reduce these now. Remember, in people that have open growth plates, okay, we need to exercise a ton of caution here. All right. If you don't get a successful reduction after one or two attempts, you splint them and you send them, because they may have an associated fracture. Okay, if you're dealing with a high school athlete or an adolescent, be extremely careful. Okay, if you don't get a successful reduction right out of the gate, don't keep tugging on it. Right, um, get them splinted and get that sent. So ultimately here, okay, the way that you would ultimately reduce that is you would stabilize essentially at the distal metacarpal, right? And then you would essentially use your other hand and you would pull traction, right, on the metacarpal itself. And then you would essentially have to bring it around and relocate it, uh, with the metacarpal itself. Okay. So when you splint those, guys, though, it's really important. When you put a splint on for this kind of stuff, guys, how far down should the splint go with this type of an injury? If you're going to splint somebody, how far down do you think you should take the splint?
All the way to the forearm.
Okay.
If
But
you're
like, But okay, but like distally though, like how far distal should it go?
Oh, well, you'd have to stabilize the fingers, so you'd have to go all the way to the end.
Yeah, go all the way to the fingertip. Absolutely yes. Okay, splint them from the forearm through the wrist all the way to the fingertip. Okay, and sometimes what I'll do with these guys is I will actually splint them. Right. So some people like with these, I'll split them actually bottom and top. Right. So I'll do like some orthoplast. I'll split them from the bottom, and then I'll come back in and splint them from the top, almost kind of like sandwiching the finger. Right. Because the bottom line is that if they've dislocated, either palmarly or dorsally, right? Um, I need to essentially keep them in neutral and make sure that if I did reduce them and it actually and the dislocation has been reduced, right? I need to go ahead and stabilize that appropriately, right? By stabilizing that essentially bottom and top, right? So palmarly and dorsally. Does that make sense?
Yeah.
Okay, very good. Okay, all right. Obviously, guys, finger fractures. You guys are going to see these a ton. Um, and this is and the same thing. The same thing goes here. Okay, with your finger fractures, these guys, because remember, even though a phalanx is a small bone, it's still a long bone. Okay, so they will rotate and shorten. All right. So the bottom line is that we need to go ahead and uh, you know go ahead and split these guys. Now, there's a technique that we utilize, and you guys have probably all done this. You guys are familiar with the use of buddy taping, right?
Yeah.
You guys have buddy taped probably plenty of times. Okay, buddy taping is an excellent way to split a finger. Now, what I would do in this case is I would actually go ahead and I would use like an aluminum splint distally to splint this. All right, and then I would actually go ahead and gently buddy tape these guys together for added support. That's how I would actually splint these. Okay, until they can be obviously repaired or reduced. Okay. So there's another one. This is a classic example. This is a classic example of an oblique finger fracture. Okay. So, all right, guys, let's say, and we're gonna kind of quiz you a little bit here. If you have someone that comes to you and say, yeah, somebody, I got punched in the hand, or I got my finger smashed between a door, and/or I dropped something on my finger. What types of things do you think that you're going to look for on your exam that are going to help you decide whether or not to refer someone for X-rays? What are you going to look for?
Well, you're gonna want to look for like the puckering
Yep, skin.
or like bumps.
Yep, yep. Okay. What about at the fingers though? And Izzy, you're absolutely right. You're absolutely correct. Because we've already said that when a long bone fractures and shortens and rotates, right? What do we think we might see at the fingers?
Rotation.
Rotation. Look for rotation. Look for skin puckering. Look for deformity, right? And look for localized swelling. Okay. Generally speaking, guys, the fingers, okay, when they're injured, the one thing you guys are going to notice is if someone has um, basically a phalangeal fracture, it's not it's not uncommon for phalangeal fractures to swell quite a bit. Okay. Now, the other thing though too is you need to ask yourself, where is the swelling? Is the swelling at the joint, or is the swelling actually at the phalanx itself? Right. If you see swelling over the phalanx itself, generally speaking, index of suspicion for fractures needs to go up. Okay. So rotation, skin puckering, evidence of local swelling at the phalange. Right. That makes sense to everyone, I'm assuming. Yep. Okay. There's an example of obviously a distal phalanx fracture. It's crazy. So if you ever see the plates that they use for these, the plates that they use for finger fractures are super, super small. It's pretty crazy. Um, okay. So guys, right along the same lines, okay, of finger fractures, obviously, you guys will also see are phalangeal dislocations. right? Phalangeal dislocations. You guys are going to see these a ton. Okay, with football, hockey, even baseball, you're going to see these a ton. So this is an example of essentially a volar. Um, yeah. So essentially a. I'm sorry. This is an example of a dorsal dislocation, right? And you can see obviously where we have our PIP, uh, sitting directly on top of the and this is actually directly on top of the uh, proximal phalanx here, and it's obviously stands to reason, right, that the lateral collateral ligaments have probably been completely and totally disrupted, right? But with reduction here, guys, okay, these are pretty simple. So essentially, what we would do is we would essentially stabilize the proximal phalange, and then we essentially take our other hand and we put our hand on essentially the distal and middle phalange, and we pull traction. We pull traction, and then we bring the finger back around the metacarpal, right? And I can show you guys this in class tomorrow. But generally, what I will do when I have somebody come to me that's dislocated a finger, I'm going to take essentially one hand and I'm going to stabilize at the and it's still essentially intact or in. And I'm going to take my other finger and I'll actually put my fingers around the joint, right? And I'm just going to kind of put a little bit of pressure and kind of squeeze, right, at the distal phalanx a little bit while applying traction, and you're going to feel this, and it'll pop right back in. Generally speaking, then I would obviously splint this. We need to get them over for X-rays to rule out any avulsions or anything like that. So let's say that you have someone, okay, and they have a finger dislocation, and you've tried reducing them 3 times. You can't get them back in, and it just hurts like hell, right? And they're screaming and hollering, and you can't get them back in. What do you think is a primary complication if you can't get the finger back in? If you're having a hard, okay, potentially a fracture, right? Okay, very good. Okay, nice. All right. So conversely, okay, here's the difference. And you can see here, this is actually a volar dislocation or a volar or palmar dislocation. Now, one thing to notice, okay, in the event that someone dislocates volarly, all right, you need to really be careful, and you need to evaluate for volar plate injuries. Okay, volar plate injuries can occur as a result, obviously, of volar dislocations. And a volar, as we'll see in a minute, okay, a volar plate injury can actually result in a pseudoboutonniere deformity. Okay, because we're going to talk about finger deformities here shortly. So, yeah, anytime that someone's finger dislocates, essentially, volarly, check the volar plate, make sure they're not tender, because if they are, they're going to need to be seen, and that volar plate might have to be repaired, so they don't actually develop a finger deformity down the line. Okay. Okay, another dislocation. These are, guys, these reductions of these are super simple. You're stabilizing, you're grabbing the segment that's essentially out, you're pulling traction, and obviously realigning it and relocating it with the phalange below it. Okay. So then obviously here's one of the thumbs, so MCP joint dislocation. Now, guys, does this make sense? I mean, as far as reduction techniques, it's pretty straightforward. Does anybody have any questions in regards to like how you would actually reduce a finger?
You basically just pulled traction, right? And then
Yeah,
stabilize one end.
yep, you've got to stabilize. And so basically on the phalange that's not dislocated, you've got to stabilize. Then your other hand is going to go and it's going to essentially grab, right? It's going to essentially kind of grab and cup the proximal phalange, and you're going to pull traction. What I typically tell the patient is like, hey, go ahead and look away for me, because they'll freak out if they see their finger go back in, right? So I say, hey, go ahead and just look the other direction for me. I'll grab the finger, I'll pull traction, and we'll get them back in. So
Could we just quickly go over that tomorrow? Like in
absolutely
the beginning?
yes, absolutely yes. I'll walk you guys through that. Not a problem. Okay. All right. Okay. So whoops. So sometimes you guys will see this, and this is not very common, but it does happen. So sometimes if you guys see like basically distal phalanx fractures at the finger with an injury to the nail bed. So let's say somebody got, maybe they get their finger caught, like slammed in a door, right? And they fracture the distal phalanx, but they also have an injury to the nail bed, right? Um, that is what is that's what's known as a Seymour fracture, guys. And you guys, you won't see that too often, right? But Seymour fractures are pretty nasty. We had that happen in a volleyball player one time. The doctor had to kind of come in and and also kind of basically resew the nail bed into the finger, which was kind of gnarly. But Seymour fracture, so distal phalanx fracture with nail bed injury. Okay, okay, cool,
Are
cool.
there any like, so like in the ankle, we had the Ottawa ankle rules. Was there anything like that for like the wrist? Just like, or specific ways to check for a fracture other than like, obviously you feel they're going to be tender if they had an injury, whether it's fractured or not. But
Right.
if it's fractured, it's obviously going to be way more tender. They're going to be extremely painful. But like, are there rules or is that not a thing for the hand?
For the fingers, I wish that was the case. I wish that was the case. Here's the thing, right? Generally speaking, in the hand, the one advantage that we have anatomically is the fact that we have so much anatomical prominence in the structures that deformity is really easy to appreciate, right? Not so much with the ankle, not so much with the knee, because we have a lot of soft tissue that actually crosses those joints and can actually obscure bony deformity when it exists. That's kind of a complicated answer. But does that make sense? Am I making sense when I say that?
Yeah. So it's like if there is a fracture, it's relatively obvious as compared to other parts of the body.
Generally going to be relatively obvious, or you're going to have a pretty high index of suspicion based on what you see, right?
Yeah.
And that's why we're looking for shortening. That's why we're looking for rotation. That's why we're feeling for crepitus. Does that make sense?
That does.
Okay. All right. Cool deal. All right. So let's get in, guys, to the the biggest, and we talked about this yesterday, but let's go over this again. We need to really quickly talk about, right, um, the tendons of the hand. All right, again, and just kind of go over them. And like I said, I will get this in a PowerPoint somehow for you guys. Um, but here's what I want to show you. Okay, let's. I'm going to show you guys. Let me find it. Let me find a good picture, a better picture actually. All right, so we talked about yesterday. Whoops. All right. There we go. All right. Okay, so generally speaking, guys, we're going to talk first and foremost about essentially the mallet finger. Okay, so the mallet finger itself, essentially, guys, is disruption of the extensor tendon of the finger at the DIP. All right, so here, let me show you an example. Here's a mallet finger. Okay, so this is what this essentially looks like on X-ray. Okay, this is where we've essentially disrupted the extensor tendon, right, and we lose the ability to extend. Okay, and this is a pretty simple mallet finger injury. Okay, so this one does not have obviously any bony involvement, but here's obviously an example of how we would splint this. Okay, so obviously we would splint these from the top, going above and below the DIP, right? And there are different types of splints that you guys are going to see used. Aluminum splints, obviously, a stack splint, and then obviously a ring splint like this. Okay, we have these. I've actually never used the ones over here on the far right. I've generally used a stack splint and aluminum splints. but I think that apparently we have these on campus somewhere. All right. So obviously, guys, a mallet finger is going to occur right via a direct blow, generally, right, and it's going to essentially cause the DIP to be forced into flexion. Okay. So the other thing that we need to also that we need to remember as well, though, okay, is that with a mallet finger, okay, we tend to think of these as happening, okay, as essentially just happening in athletic contexts, right? But the bottom line is that let's say that you're in the kitchen, right, and you're making, you're making Thanksgiving dinner, whatever you're cooking, right, and you slip with the knife and you cut your finger, right? You cut your finger open, you know, and you have a crazy laceration on your fingertip. You can also obviously lacerate the tendon with a knife, right? So you see here, obviously, we have different types of mallet fingers, right? So we have types 1 through 4, and then 4A, B, and C. Okay. Now, obviously, type 1, we're gonna have a bony avulsion there. Type 2 is essentially just right a laceration, um, or just essentially a laceration of the tendon, right? And then type 3 obviously is going to occur with full laceration of the tendon and finger there, right? And then we have associated fractures uh, at the distal phalanx, right? Type 4B is where we actually avulse the distal phalanx along with the tendon, right? And then obviously we have a complete fracture through the distal phalanx with the tendon intact in type 4C. Okay, but ultimately, my point is, right, is that there are generally speaking, um, you know, other ways to essentially have a mallet finger other than simple loading of the finger as we see right in athletic populations. All right. Find. Okay. Okay. So this is actually what a mallet finger. Let me reshare this. Here's what a mallet finger would essentially look like, right? Um, in real life, and I'll actually share this picture here. Okay, so this is what you would see with a mallet finger. Okay, so you're going to see this deformity at the distal phalanx. Okay, and the patient will obviously not be able to actively extend the finger. Okay, this is the telltale sign. The patient will not be able to actively extend the finger. So if you ask him, I'll show you guys this tomorrow. If you stabilize at the PIP and ask them to actively extend, they're not going to be able to do it. Okay, if they've got a mallet finger, they will not be able to complete or achieve full extension of that distal phalanx. Right. Okay, so that's a mallet finger. Okay, and that's when this happens at the DIP. Okay, but what about um, when it actually happens, right, at the PIP? All right. So when this happens at the PIP, and let me reshare. Okay, when this happens at the PIP, we actually call this a boutonniere deformity. Okay. All right. So here's an example of a boutonniere deformity. Okay, you can see that. Okay, so like we talked about yesterday, this is where we have a buttonhole deformity where we essentially have a tear in the tendon at the PIP. We have a little tiny buttonhole deformity that essentially it slips downward over the bone, and it changes the angle of pull of the extensor tendon to where the tendon is actually still intact at the DIP, right? But right, it essentially pulls the finger down into like a boutonniere type of shape like this. Okay, and obviously it's covering my hand, but you can see that. Okay, so that's what the boutonniere looks like. So, and the only difference here being is the location of where the tendon was injured, right? So mallet fingers at the DIP, boutonniere happens at the PIP, okay, and you're going to have this type of deformity. All right. Any questions so far about the difference between a mallet finger and a boutonniere deformity?
All right, so the one at the PIP, what we're looking at right now, is called the boutonniere or a buttonhole.
Okay, Bennett, you're asking a great question. It's called boutonniere deformity, but the boutonniere deformity happens because there is a buttonhole deformity. Let me unpack that real quick. I'm glad you asked that question. Freaking whiteboard on. Try to find a way to draw this. Here it is. Okay. Okay, Bennett. So your question is a fantastic one. All right. So Bennett, I love this question. Let me explain this. All right. So here's the deal. The boutonniere deformity happens, okay, because of the fact that there is, right, a, shit, pardon me, um, that there is essentially a buttonholing, right, of the tendon itself, right. So here's the tendon. Can't use my finger. All right. Now, Bennett, we're at the PIP. Here's your buttonhole deformity that happens at the top of the tendon. Okay. So here's my extensor tendon. Here's my buttonhole deformity.
You want to share it?
Oh, damn it. Yeah. Sorry, guys. I'm a little edgy this week. I apologize.
Nope.
Uh, let's, yeah. Continue. All right. Okay. You guys probably still can't see that. A window. Hey-oh. All right. Here we go. Finally. Okay. So Bennett, here's the tendon right here. You guys can all see this, I'm assuming, yeah?
Yeah.
Okay. Here's the extensor tendon right here, Bennett. Okay. So the buttonhole deformity is right here. Okay. In the substance of the tendon. All right. You see it? Looks like a buttonhole on a shirt. Now, here's the problem. Because we have these intact bands both here and here, ultimately the bone, all right, begins to essentially kind of poke through. The bone essentially begins to kind of protrude through the buttonhole ever so slightly right here. Okay. And as that happens, the buttonhole deformity continues to widen, and then the tendon actually will actually slip down over the bone. Okay. So here is my phalanx. Shit. Sorry. Here's my phalanx right there. Okay. Now I have a buttonhole deformity. My tendon, Bennett, should be here. Okay. But because of the buttonhole deformity that exists here in the tendon is now essentially, it's still intact, but it has actually slipped down, and the tendon is essentially now sitting on the side of the finger like this. It's not up here. It's slipped down here. So it's intact here and it's intact here, right? So now I have essentially a boutonniere deformity because the angle of pull of the tendon has changed. It's no longer on top of the finger. It's actually down at the side because of the buttonhole deformity. Am I making sense?
Yeah. Can you spell that out? Boutonniere?
Yeah, boutonniere. It's always a challenging one to spell. Okay. So boutonniere deformity. Okay, just like this. Boom. There it is. Let me double check my spelling real fast. Yep. Okay. That's a boutonniere deformity.
Go back.
Yes.
Never mind. I got it. Wait, I got it.
Oh, here it is. Here it is. Right there. Boutonniere deformity. So yeah, to be clear, the buttonhole deformity happens in the substance of the tendon, right? Right in the middle, basically. But because the tendon's no longer intact, the tendon slides down to the medial and lateral aspect of the joint itself, right? And pulls the finger into a boutonniere deformity. Because remember, if you can imagine, Bennett, the tendon still has to maintain a straight line of pull because that's what the tendon does. And so when the tendon slips downward, right, the tendon remains in a straight line, but pulls the PIP up through the buttonhole, right, and then creates the deformity.
Okay.
All right, guys. So I know it's time. Yeah, but I will. So, any questions before we call it a day? Or before we say peace out?
I'm good.
Nope.
Okay. Right. Well, you guys rock my socks off. Okay. Thank you for being you. And I will see you guys in the morning. Okay. We'll do some obviously hands-on stuff. We'll work on dislocation reduction, and then we'll talk about our last few finger pathologies. And then that's it. That's the course material. Crazy times. I can't believe it's already December and that we've covered all of this. It doesn't even seem possible. But okay, guys. The other
See you
thing that
tomorrow,
I
Wade.
will see you tomorrow, and the other thing that I will do, I want you guys. I'm going to obviously open up the SRIs, the evaluations for this class. I want you guys to please do them because your feedback matters a lot to me, and I want to hear from you guys as far as ways that I can obviously better improve the course. So, yeah, but I'll open those up for you guys and just get those done for me when you can. Okay, but I'll see you guys tomorrow morning. Okay.
Thank you.
You're welcome, guys.
Bye, Wade.
Bye, guys.